So, right, so I've shared the link on the group and I'm just starting the presentation now. Okay, so if it's possible for you to join, that's wonderful. And if not, that's also okay. I think it should come through the super link, right? Open in app type of link should be there. Okay, okay, guys, please answer, keep answering in the live chat. What do you think is the diagnosis? So we have a 32-year-old female with progressive exertional dyspnea. Orthopnea is also there. Okay. Don't see the diagnosis, please. Yeah. Dyspnea, orthopnea, occasional hemoptysis, irregular pulse, mid-diastolic murmur, best heard at the apex in the left lateral position. Atrial fibrillation is there. Thickened mitral valve is there. So see, this is actually how the valve appears normally. I just jump. Okay. Yeah, so normally there should have been enough space between two leaflets. These are mitral leaflets actually, anterior and posterior mitral wall leaflets. So as this is thickened with each other, we can say this is mitral stenosis basically. Okay, and there is the same mitral stenosis peak related with that. Okay, so that was our answer. So diagnosis is mitral stenosis. It's a mid-diastolic rough rumbling murmur, and most definitive investigation in this case would be echo. Okay, 2D echo, no doubt. Right, let's verify. Yeah, the answers are correct. Okay, so they have also given this is anterior mitral valve leaflet, this is posterior mitral valve leaflet, this is normal echo, and in mitral stenosis echo appears like this. Okay, so I hope my pointer is visible to you. If not, I'll just make sure that I have pointer or something. Yeah, laser pointer. Okay, so yeah, this is basically mitral stenosis, clear to you. Okay, चैट सेक्शन में बताना है आपको, ठीक है? So this is the classification of the murmur. Systolic murmur, we have mostly regurgitant murmur. Diastolic, in which we have, if it is decrescendo, that means early pitch is high, then there is regurgitation. Otherwise, if it's decrescendo crescendo, then this is always mitral stenosis or tricuspid stenosis. Okay, so please remember, in diastolic mostly it is stenostic murmur, and in systolic it is regurgitant murmur. Okay, and if it is crescendo decrescendo, then it can be also stenosis, but polysystolic is usually regurgitation, mitral regurgitation and tricuspid regurgitation. It's very easy chart. Okay, just remember this is very important. Coming to the next case now, please, 8 of you whoever are watching this, please answer this case. It's really nice case. ECG is very nice over here. Look at this patient. It's ECG. What do you think with the ECG? Yes, anybody? Yeah, yes, anybody in the chat section? Yeah, come on, guys. You have to answer this one. You can't see the slide. How is this possible? Because I can see. Acha, slide has not changed. Okay, slide has not changed. Only first slide is there. Oh, ho, 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 ho. I think just a second. There must be some problem. Yeah, I could only see just a first slide is there. Slide change is not occurring, na? Just a second, na? Just a second. Just, yeah, now it was occurring. Yeah, now it was occurring. Okay, now it's occurring like this. It's occurring, I guess. Okay, great, 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 great. Sorry, 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 sorry. Yeah. Now, if possible, please answer this one. What do you think is the answer for this one? Okay, so we discuss about this where I explained about these things. Ki how do you make it that if it is mitral stenosis or not, and how this is how the normal appearance is. Okay, yeah. So now this is how the heart murmurs will be the classification. Now let's start with this case 2. Yeah. So can you answer this one? What do you think is this? So these are very important OSCEs. Can you answer, anybody? Can you answer this one? It's able to answer this. This is not very difficult there. Yeah, anybody in the chat? Yes. So it's very easy, right? It's P mitral. Look at this P mitral. This is P mitral, right? The width of the P wave is more than 2.5 boxes, right? So this is P mitral. The patient has left atrial enlargement. So if you see the history, patient is having fatigue, palpitations, displaced hyperdynamic apex beat is there, pansystolic murmur radiating to the axilla. So diagnosis is mitral regurgitation. Murmur features are mostly it's a pansystolic type of murmur. They have already given the features itself. Pansystolic type of murmur which gets aggravated when patient moves to the left. Okay, and indication for surgery. So in severe mitral stenosis, okay, when ejection ESD is more than 40 mm, okay, or ejection fraction is less than 60%. So this is the indication for the surgery in these patients, right? Let's move on to the third case now. I hope you are able to see this. Can you tell about this third one? Important valvular heart disease we are discussing. Okay, so 70-year-old with exertional syncope and chest pain, harsh systolic murmur radiating to carotids, slow rising pulse. Anybody? It's very easy. Come on, guys. I expect more from you. Yes, very easy, right? Aortic stenosis radiating to carotids. Whenever you have the syncope, angina, syncope, and dyspnea, ASD, in the complaint with this harsh systolic murmur radiating to the carotids, that's with the slow rising pulse, that's classical for the aortic stenosis. Okay, yes. So remember, aortic stenosis, ejection systolic murmur, best heard at right second intercostal space, radiating to the neck. And what are the surgery indication? Symptoms or wall area less than 1 centimeter. That means severe AS. Okay, in MS also we say less than 1, it's a severe MS, but here also severe AS. Okay, or if peak gradient is more than 40 mmHg, then surgery indication is there. So this is very important point for DNB students, for NEET students, as well as for MRCP, USMLE, any part of student. Okay, remember this. A surgery indication, if symptoms are all area less than 1, it has to be done, or peak gradient more than 40 mmHg, it has to be done. Let's go to the fourth question now. 38-year-old male with palpitation and awareness of the heartbeat while lying down. That means he is having that, obviously the palpitation, the feature, it's described in detail over there. Then early diastolic murmur at left third intercostal space is heard. Wide pulse pressure is there. Collapsing pulse is there. So when do we see collapsing pulse? Everything is explained over here in the history itself. Can anybody tell me the diagnosis? Yes, guys, come on, quickly. Come on, boys and girls. There is actually a lag, a bit lag. Exactly, Bharat. This is aortic regurgitation. Okay, so because you are seeing palpitation and all, that's okay. But this early diastolic murmur, this is very classic, right? At third intercostal space, and it is mostly crescendo decrescendo. Yeah, diastolic runoff, aortic regurgitation. Very nice, collapsing pulse. So this is very important concept. But can you tell me like what would be the cause of 38-year male having aortic stenosis? Usually aortic stenosis will be seen in the older population if there is a aortic sclerosis, right? But what would be the cause of 38-year-old having aortic stenosis? Do you know anything like that? Anything? Have you heard about that? So this question you can get in Viva. What are the causes of aortic stenosis in young population? Yes. Okay, I hope you know, because there is a lag. I'll just keep moving forward. Okay, so the answer is aortic regurgitation. Peripheral sign, as we know, Corrigan's pulse is there, dancing carotid, Demusset sign is there. Basically, it means the ovula is moving. Quincke's sign is there on the nail bed. Then wide pulse pressure is there. Then this nodding sign is basically there. Then Demusset is, I think, nodding. Mm, then we have uh, this collapsing pulse is there. Okay, along with that we have pistol shots on the femoral artery. Okay, then what else we can have in aortic regurgitation? This lighthouse sign is there. Okay, the flushing of the uh, frontal or your forehead is there. Okay, so lighthouse sign can also be seen. So these are the various signs of the aortic regurgitation. Definitely test is echocardiography and Doppler for sure. Now case 5. 50-year-old male with pedal ascites, JVP with prominent V wave, pan-systolic murmur increasing with inspiration, and right atrial enlargement is there. When do we see right atrial enlargement? In which cases? Okay, pedal is there, ascites is there. So this has to be heart failure. Now just look at the pan-systolic murmur. So a very rare cause could be there here, or not very rare cause, but a common cause, but which is usually not a primary common cause. It is usually the secondary of either MR or MS or ARAS. Okay, so that's basically the diagnosis in this case. Yeah, anybody? Yes, you are correct. This is tricuspid regurgitation, and murmur occurs. This is basically pancytic murmur increase with the inspiration, called as the Carvalho's sign. Okay, and causes pulmonary hypertension more than the rheumatic cases. Right. Moving on to the sixth case, which is second last case. 18-year-old female with exertional dyspnea, ejection systolic murmur in the left second intercostal space. Ejection systolic murmur is there. Okay, no cyanosis, and right axis deviation is there, R which is there. So it's very rare, but it is pulmonary stenosis actually, and it's not very common though as a primary pathology, but can be seen with the Eisenmenger syndrome. That's it. That's the basic stuff. Usually it's not that very common, and in the rheumatic fever also, it's not very common. Okay. So pulmonary stenosis, congenital is the most common. Management, balloon valvulotomy is symptomatic. Moving on to the seventh case, that is the last case. Here you can see 60-year-old female is there with dyspnea, fatigue, AF is there, MS, MR both are there. Okay, what will be your diagnosis? Dyspnea, fatigue, diastolic murmur with pansystolic murmur at the apex. So MS plus AR with the heart failure, obviously that will be the diagnosis. Okay, dominant relation if they are asking, depending on which would be the dominant, so that will be AR, MS, sorry, MS will be there. Okay, considering the age group, so anything can be dominant depending on the echo we can confirm. Okay, so by echo we can confirm valve area, regression volume. On the basis of that, we can finalize the dominant lesion. All right, the treatment should be tailored as per the dominant lesion. So this is just a basic exercise we did for this discussion. I hope you like this short 7 questions about the valvular heart disease and the CVS OSCE which can be asked to you. Okay. All right, guys. Thank you so much. If you have any doubts, please let me know. Thank you. We'll do a few more CVS OSCEs soon.